welcome to another installment of our New York Healing Communities Study webinar series. I'm James David, Senior Project Director of HCS in New York and your moderator. This series is hosted by the Social Intervention Group, which is housed in the School of Social Work at Columbia University. On behalf of our study's principal investigator, University Professor Nabila El-Bassel, I wanted to thank our funders, NIDA and SAMHSA, and investigators from the following academic institutions who've joined together to implement HCS in New York and sponsor these talks. Columbia University's Chosen Center on Addiction, the Irving Institute of Clinical and Translational Research, Mailman School of Public Health, Columbia University Information Technologies, City University of New York's Graduate School of Public Health and Health Policy, Albert Einstein College of Medicine, University of Miami Miller School of Medicine, Cornell University's Department of Population Health Science. Today's topic is community perspectives on system dynamics modeling to inform the implementation of evidence-based interventions to reduce opioid overdoses and fatalities. Please submit your questions via chat, and we will try to get as many of them as possible toward the end of our hour together. Now, I'd like to turn over to my colleague, Professor David Lonsberry from the Albert Einstein College of Medicine. Dr. Lonsberry, the floor is yours.
Thank you, James. So our presentation is organized into 3 parts today. Part 1 describes how we are using system dynamics modeling to support the healing community studies, community engagement intervention via what we have been referring to as our New York Systems think tank. Part 2 overviews the actual system dynamics model that we're using to support the study. And then we are going to have representatives from 2 of our 16 New York communities, both from Wave 2 in the study, give their perspective on how their participation in the systems think tank has supported their implementation decisions. Next slide, please. So we wanted to start by thanking members of the New York Systems think tank who are not presenting with us today, and in particular, Dr. Terry Huang at the CUNY School of Public Health, who's a major co-investigator on the study. We also wanted to thank James David again and others at the Columbia School of Social Work for helping to organize today's seminar. By way of disclaimer, we just wanted to point out that this research is supported by the National Institutes of Health through the NIH HEAL initiative, and that what we're sharing today is solely our responsibility, the responsibility of us as co-authors and co-investigators, and does not necessarily, but may represent the official views of the NIH. So next slide, please. So we wanted to start with the description of the New York Systems think tank. Next slide, please. And I thought it would be useful just to kind of remind everyone or reorient everyone to the goals of the Healing Community Study. They are fourfold. They are to work with community coalitions to implement a community engaged, data-driven intervention, and to use those community coalitions to stand up strategies that will reduce overdose deaths through implementation of 3 buckets, or we sometimes refer to them as menus of evidence-based practices: overdose education and naloxone distribution, OEND, medications for opioid use disorder, or MOUD, and then safe prescribing and dispensing practices. We are also looking to achieve a lens that supports health equity to reduce disparities in how we are standing up these interventions. And we want to really learn how to kind of like share lessons learned from the participating communities, and in particular, help the communities that are participating sustain what they are starting through the study. Next slide. So we are applying system dynamics modeling as a novel way to support the CTH intervention, the communities that heal intervention. That is the model that is supporting a process of community engagement. The CTH is organized into 6 phases, and the New York Systems think tank activities basically support mainly phases 3 through 6. So going from looking at ways of understanding existing information about communities all the way through action planning, implementation, and then sustainability. System dynamics models are representations of feedback structures. And these feedback structures are used to kind of visualize a problem of interest and particular ways of maybe resolving that problem. These feedback structures are often kind of like captured in diagrams that system dynamicists refer to as causal loop diagrams. And these causal loop diagrams are sort of like a blueprint, if you will, of how to kind of like build an actual simulation model that is often referred to as a stock and flow diagram. These are actual equations, both algebraic and differential, that represent these feedback structures. And by working through a process of validating the model, you can then run the model in a way that simulates both the problem and potential solutions in the model, using the model. Next slide, please. And what we are doing in New York is using the model to support the CTH process, but through our systems think tank, we've set up a variety of activities that are designed to engage multiple stakeholders participating in the study: program managers, data coordinators, community engagement facilitators, and coalition members from all of our counties, Wave 1 and Wave 2 communities. There's 16. And we are basically using the think tank to kind of communicate core systems thinking concepts and demonstrate how the model can be used to inform ways of making data-driven decisions about how to stand up these evidence-based practices to address the morbidity and mortality of the opioid epidemic or the crisis in their communities. We had a series of group sessions that were basically for people participating in the coalitions across our communities initially, and that was carried out during phase 3. We explicitly used the model to simulate the action plans that were a product of phase 4. And then after delivering those reports and reviewing them with the communities, we've been engaged in basically ongoing consultation, and we've been generating systems think tank reports that often feature important variables and show how the model's performing across the 16 communities as well as within the community. Next slide, please. Ideally, system dynamics models are highly participatory. It is an iterative process to kind of basically come up with a way of understanding the problem. And a lot of that is coming from stakeholders, from their perspective. Stakeholders basically are engaged in activities that help them express how they see the problem from their perspective. And we talk about eliciting their mental models. These mental models then are used to kind of create the actual stock and flow diagram and to formulate the equations. And we use many different sources of data, and Nassim will be talking about that to kind of calibrate the model. In this particular study, we built a model that works well to kind of simulate the problem at hand across all 16 of our communities. So the system structure is then simulated. We look at the results of that simulation and discuss its utility. And over time, we're building confidence in how we're using data, how we're representing the problem, and how we might resolve the problem. Next slide, please. And basically, for this project in particular, we really want to kind of improve the quality of community decision making. And The system dynamics model is hypothesized to really serve that purpose by synthesizing and integrating multiple sources of information, including information that we are using, that we're identifying from the published literature, as well as expert opinion. Very often, we do not have all the data that we would like to represent particular variables in the model, for instance, prevalence. Nassim will talk about that. So it's a way of mitigating certain data limitations and uncertainty. In the context of public health, often we're using surveillance data that is quite old. So we need to we can use the model to kind of address the challenge of like working with data that may not be as current as we want. And then most importantly, the model allows us to actually run virtual experiments where you can really compare different strategies for addressing the opioid, in this case, the opioid problem in the local context, and think about basically how long it might take to create a certain impact and what mix of interventions would be most effective. And we do this via simulation analysis. We are sharing our model and other information about how to use it in a website that we've created, and the link is there. And this is something that Nassim will also talk a little bit more about in the next part. Next slide, please. So now I am going to turn things over to Nassim, who's going to overview the system dynamics model structure. That's its equations and whatnot, and its simulated output, its behavior.
Thank you, David, for giving an overview of the role of the systems think tank in the New York Healing Community Study. So in this section, I'll give an overview of the system dynamics model that we have built for the study and give an overview of its structure and behavior. So in the next slide, this is a simplified snapshot of the entire model. The model consists of different sectors and includes different feedback loops that capture the dynamics of the opioid epidemic in the 16 communities of a healing community study in New York. So on the next click, you would see the first sector of the model, which captures the dynamics around the social influence of how people get exposed to opioids, how they would initiate misuse of opioids, and escalate to opioid use disorder. The next sector is describing how the drug supply, the opioid supply, the changes in opioid potency, and its impact on risk of overdose is leading to increase of overdose fatalities over time in different communities. The third sector is describing an important dynamic and structure around community awareness that defines how, by increasing of fatalities in different counties, awareness goes up, which would potentially prevent further initiation of misuse over time, and also serve as a factor that would prevent further opioid use disorder in the county. The fourth sector describes the distribution of naloxone kits and further harm reduction to preventing fatalities. This is an important intervention also in the New York or the healing study that David pointed out. And the fifth sector highlighted here on the next click. Yeah, this is the capturing the dynamics around treatment for opioid use disorder. So in our model, we also capture how people initiate medication for opioid use disorder, and also other types of treatments, including behavioral treatment, detox, and etc., which is all feeding into the opioid dynamics, epidemic dynamic in each county. Community awareness does have a role also in improving awareness of MOUD availability and capacity in the county. So the next slide, we basically shows that we have, we formulate and simulate the model. We calibrate it towards different data series for every county. This is a snapshot of a web-based portal that we distribute the model through this portal, and each county has their own link, and they can log in and use the model, experiment with it, run these different scenarios as shown here with these different levers. They can pull them on that lever and experiment the combination or different single interventions and how it affects the overdose fatalities or other outcomes as shown on this graph. The next slide, we show an example of how these simulation runs look like. For example, for Broome County, this is simulated data shown on this graph. And it shows the trends over time beginning in 2012 up to 2032. We have calibrated the model for data between 2012 and 2021. And the future or after that, it's all estimated and simulated in the model. The model pretty much fits well with historical data. And then, as I suggested earlier, so we can then run different simulation scenarios. So you see that the green line is the base run without any intervention or additional interventions implemented. The first number one, or the line with the diamond markers, shows if distribution of naloxone is increased by 2 times and bystanders availability is also increased by 10%. And then the third or the second intervention colored in pink, or the circles, it shows if MOUD initiation is increased by 2 times and retention is improved by 20%. The third scenario is the combination of MOUD and OEND interventions. And the fifth one, or the one that shows more of a robust impact in reducing overdose fatalities, is the one that also includes improving awareness in the community, which leads to further prevention of misuse and initiation of opioid use disorder within the county. And that is showing more of a robust outcome in reducing fatalities. We also can show other outcomes from the model as estimated, such as the next slide shows the opioid use disorder prevalence within the county, and how these same interventions, how it would impact and change that trend over time. And also to highlight that these scenarios start at 2022, corresponding with how the HCS actual implementation starts, and it is sustained over time. So interventions continue to be implemented for the future. The next slide also shows another set of experiments with data for Chautauqua County. So we simulate the model again with running these scenarios. And interesting here that, all interventions are showing some decline in overdose fatalities. Awareness is not showing as much of an impact, additional, but however, it's actually the cases that awareness has led to drop in misuse rates already. So additional awareness and to prevent misuse is not creating further decline. And this, interestingly, in this simulation scenario, as you see in the fourth and third lines. So, and then the next slide, and a similar, the opioid use disorder prevalence for Chautauqua County. This is another outcome we can explore with running all these simulation scenarios, as you see on this slide. So moving on to the next slide, we also have, just to highlight that the model, the general model structure is also calibrated for all 16 counties. So we can basically, here what we do, we're demonstrating the opioid overdose fatalities across all 16 counties per 10,000 people using a box and whiskers graph. As you see, the boxes or the central line shows the median percentile. The ends of those boxes show 25 and 75 percentile. The dots show the outliers, meaning some counties that actually are showing numbers far and above the rates for all the other counties. This shows, interestingly, the the variability in outcomes for different counties. This is also just a base run, so without any additional interventions, we're just showing how the simulation results look like across all the counties. The next slide, we also show a similar box and whiskers for opioid use disorder prevalence across all the 16 counties in New York Healing Community Study. The range between almost like 1.5 and 5.5%. And with this overall showing a decreasing trend over time, which is a good sign, and also some that are outliers. The next slide, just to highlight that, yeah, there is variability in simulated outcomes across the counties. We have calibrated the models, the model basically for all counties using data outlined in this table, using overdose death data, MOUD data, number of naloxone kit distributions and administrations, and also ED visits for opioid overdose. We simulate and estimate the risk of overdose, potency, prevalence, and also community awareness using the model structure and the feedback loops that I highlighted just a few slides ago. There's no actual data for these, but the model simulation is helping us to understand structures underlying these trends. And we do validate the model using both structurally and behaviorally, using different sources and different tests, and especially getting feedback from stakeholders and our community partners through the systems think tank process. We have revised and validated the model iteratively in the past few years. So this is really interesting that we have been able to get their feedback and incorporate that to capture some of these important trends that although data does not exist, but are really an important factor contributing to this epidemic. I will pass it on now to Matt to introduce the next section of the presentation.
Thank you. Thank you, Naseem. And thank you, David, for your presentation. We've now heard about the unique role of the systems think tank in the New York Healing Community Study, and how system dynamics modeling can synthesize a variety of data sources and support data-driven decision-making in community coalitions. We've also learned about the structure of the model and some of its behavior as it relates to two key model variables, namely annual opioid overdose fatalities and prevalence of opioid use disorder. As a senior research coordinator for the New York HCS Systems think tank, I've had the opportunity to meet many people from across our 16 communities and counties, and to convene and facilitate conversations around the use of our model and systems thinking in general. We are very, very pleased that the teams from Broome and Chautauqua Counties have agreed to co-present with us and offer their unique on-the-ground perspective of using SD modeling in their work of action planning, implementation of evidence-based practices, and thinking about the sustainability of their work as we move beyond the completion of the study. So let us move on to the third and certainly the most important part of our presentation. We will first hear from Jillian Belock, Program Manager of the Healing Communities Study team in Broome County. So Jillian, whenever you're ready.
Hi, everybody. Thanks so much, Matt, and thank you so much to the Systems Dynamic Model team and to you all for being here. So like Matt said, I am the project manager for Broome County for the Healing Community Study. And Matt, you can go on to the next slide for me. So to give a little background, Broome County is situated in central New York, and we border Pennsylvania. And in addition to that, we also border several other New York counties, including one of our Wave 2 counties, that is Cortland. We also border Delaware, Shenango, Tompkins, and Chemung counties. Broome County is an area that has a high rate of transient populations due to where we're situated, where several different interstate and intercounty highways cross paths, as well as several bus routes that come through Broome County from New York City, Pennsylvania, Boston, etc. Broome's Healing Communities Study Coalition is comprised of several different partners, ranging from prevention to harm reduction, treatment and recovery, housing providers, pharmacy, education, hospital systems, and community members with lived experience. For example, we've got folks from our local prevention coalition. We have the Addiction Center of Broome County, harm reduction organizations like Truth Farm and the Southern Tier AIDS program, both our local hospital systems, United Health Services and Lord's Hospital, and again, many other additional phenomenal partners. Next slide, please. So as far as the systems dynamics model goes, we utilized the think tank in a few different ways, including informing our action plan items, informing the coalition about the importance of integrated interventions that I'll get to a little bit more in a bit, and opening a dialogue about community awareness and prevention. The portal was often utilized during our action planning phase. It was something that we looked at pretty often to see what data we had, what data we still needed, and what was available to inform the decisions that we were making. And it was very often engaged with enthusiastically by our data subcommittee. Additionally, the systems dynamic model proved to be super useful for that data-driven decision-making in Broome County. We took a look at trends over time. We brought together community partners for a common cause, which was very exciting, providing some visualizations of the real-life consequences for the actions or the inactions that our community participated in. So for example, the first time our implementation team met with the system dynamics model team, we were able to take a look at some of those runs that Naseem had showed earlier. So when we took a look at those, the thing that we noticed, and I'm sure you all noticed too, was it's great to have all of these interventions, right? Whether it's just OEND or just MOUD. But when those things happen in tandem with one another, that's when we see our greatest results. But the thing our team noticed the most, which eventually our coalition also noticed, is the importance of community awareness in all of those interventions. And when we took a look, it wasn't necessarily shown in this particular model that's being used tonight for this webinar, but over time, as community awareness would decrease, the number of overdoses would begin to creep back up. So when communities are talking about and bringing attention to and highlighting the voices of our impact individuals that live in Broome County, folks are paying attention. Folks are wanting to contribute to an important cause. They're wanting to make folks aware of where they can get things like naloxone or access MOUD, addressing things that would stigmatize our population. But when the number of overdoses would start to inevitably decrease due to all the hard work that our coalition was doing, we would see those overdose numbers increase as community awareness would decrease. So we presented those findings to our coalition, and it was a really impactful dialogue that we were able to have about not only bringing these interventions together all at the same time, but also that sometimes our partners who maybe have one mission in mind, maybe it's a syringe service program, their mission might not align with a prevention specialist's goals and mission and vision, but this common cause was able to bring all of those different partners together. Next slide, please. So to highlight these models again, we can see the annual overdose fatalities will decrease with all of those combined interventions in addition to community awareness interventions. Next slide, please. And the same with prevalence. I think this one highlights the most to me how much all of these different interventions, these evidence-based practices, and the drive to bring our different organizations together really makes the biggest impact. So we can see that with these interventions happening just on their own independently, we inevitably see a decrease, but maybe not nearly as much as we'd want to see with all of those interventions coming together at the same time. Next slide, please. As far as insights and impacts into Broome County, again, we utilized the system dynamics model to reflect community engagement and bringing together the organizations that all, even when they're interacting separately of one another, impact one another. So on the next slide, that's going to be highlighted a little bit more. Next slide, please. So our phenomenal data coordinator, Dorian, created this Broome County concept map. So as you can see in the center, we have the Broome County community, and this is a really broad and pretty general overview of the services that are available in Broome County. So we have things like MOUD access, peer support, Narcan training and distribution, stigma education, our pharmacies, things like that. So this also looks like a representation of our coalition as well as the community at large. So one of the examples that we can kind of bring up locally is when we outlined our action plan, one of our interventions was increasing access and retention to MOUD services. So, you know, as a county-wide entity, we disseminated our RFPs and we had agencies apply, and inevitably the awards were given to the Addiction Center of Broome County. They have a robust peer program, they provide MOUD, and are pretty well established in the community. So ACBC, or the Addiction Center of Broome County, is touching MOUD access, peer support. They're also touching stigma education and pharmacies and medical providers. And another one of our interventions is MOUD education for our providers who essentially work in primary care and behavioral health care settings. And that award was given to Truth Farm, one of our harm reduction coalitions. So at a coalition meeting pretty recently, we were talking about some of the barriers that our partners are facing, and it was really great to be able to highlight that these interventions have to work in tandem with one another. So the Addiction Center of Broome County's peers had indicated that sometimes they were having trouble connecting the folks who needed services to access MOUD via primary care. And Truth Farm is providing education to our primary care facilities. So it was really great to see that even though these interventions have different goals, they inevitably have to work in tandem with one another. And we wouldn't have been able to really highlight the visualization of that and give a lot of context and open up the dialogue around that without having access to the system dynamics model. So that is, I believe, my last slide. Am I correct in that? Yes. Thank you all again so much. Thank you to Matt, and I'm looking forward to the rest of the webinar.
Thank you, Jillian. Very excellent presentation. We thank you for all for agreeing to co-present with us and all of the work that you and your team have been doing in Broome County. We'll now hear from Steve Kilburn and McKenna Graham, the program manager and data coordinator from the Chautauqua County HCS team. McKenna?
Thank you, Matt. Go ahead and go to the next slide, please. Yes, my name is McKenna Graham, and I'm the data coordinator for Chautauqua County, and I will be presenting with our project manager, Steve Kilburn. First off, we just wanted to give you a little bit of an introduction to our county. We are a rural county, so we have around 126,000 residents. As you can see in the map, we are the most western county in New York. We are bordered by Cattaraugus and Erie County. As you can see on the heat map to the right, we have majorly centered spikes of overdose in our North and our South County. Those heat maps show the concentrations of our opioid overdoses in our county. And as you can see, they are centered around our two major highways and interstates in our county, Interstate 90 and 86. We also are one of the highest rates of poverty in New York State. Outside of New York City, we have a 17.3% rate of poverty, all of these affecting our intensity of opioid overdoses. And we also have a high intensity drug trafficking area, probably affected by those interstates going through our county. Next slide, please. Now, our whole county has really banded together to be a part of this study and to combat these opioid overdoses. These are just a few of our partners that are involved. We have various agencies, including peer agencies, hospital systems and emergency departments, treatment centers, for educational groups, groups focused on harm reduction, and various people with lived experience and many more. Next slide, please. And we also wanted to just introduce, these are our overdoses in our county, our fatal overdoses of our historical data. And this is important, we think, because it really shows the importance of the systems dynamic model and how it really mimicked the history of our overdoses in our county. And when we would present the model to our coalition, people were really impressed and eager to work with it, as it really showed this mimicking pattern of our overdoses in the past. And obviously through our models that we've seen in the past, and Steve will soon present on, it showed the various factors that will help to improve and work towards lowering our opioid overdoses. Next slide, and I'll hand it over to our program manager, Steve Kilburn. Thank you.
Great. Thank you, McKenna. And thanks everyone for participating today. I want to share a few thoughts that I have found, and I think we have found the system dynamics model to be helpful for kind of relative to even just conceptually addressing the issues of addiction and thinking through then addiction and overdoses, and thinking through then what sort of interventions are can be expected to be most helpful. How do we even think about approaching which interventions might be the most useful in our own particular context? And, I think anyone who's worked in the field for any period of time would perhaps agree that there are any number of unhelpful narratives, some of them more obviously unhelpful, some of them just simply assumed that are attempted to use to explain the behavior and what interventions will work and which ones won't and why. And insofar as some of those narratives, which in other settings may even be accurate, but don't apply in any given situation, like let's say our own county, they're not helpful. And so I think conceptualizing some items around addiction and overdose patterns has been one of the real contributions that I've seen with the system dynamics model. So if you'd like to go to the next slide, Matt. So first here, I want to just make some comments around just that the model really challenges us, I would say, to think systemically, to think in terms of the multiple interplaying dynamics and those feedback loops that you saw illustrated there with Nassim's slides, all of which come to bear upon this very complex reality that is addiction and overdoses. The next slide, please, Matt. Here's a way I think that has practical implications. McKenna earlier shared a heat map that is drawn from our OD map data here in our county. That what you saw that she shared was the entire county. This is our largest city here in Chautauqua County, Jamestown, New York. And the heat map that represents over the past 2 years where non-fatal overdoses, reported non-fatal overdoses. Of course, there are many that don't get reported, but this would demonstrate fairly accurately, I believe, those sites where overdoses are most likely. And, just to glance at this would recognize that there are hotspots, so to speak, and that there are areas in our city that are relatively untouched, at least by reported non-fatal overdoses. And this is, I think, a kind of illustration, if you will, of the realities of the multiple dynamics that come to play when we're talking about overdoses. Namely, those, as we heard Nassim reference before, the social influences that impact the patterns of both use and then overdose. Certainly supply and other social determinants that make certain areas of our community, it's true in others as well, far more at risk for overdoses than others. And I point this out because it does make strategizing in our interventions so important. A broad brushed approach, in many respects inevitable and important because overdoses do happen across our county, but that approach doesn't take into account the fact that there are multiple factors at work in overdoses that do concentrate their prevalence. in certain areas. And I think just the systems model of thinking about that shines a light on that. Next slide, please. So there's the systems thinking. Secondly, next slide, please. The systems model, I think, helps us gauge expectations for the likely effectiveness of interventions. And in fact, of course, it's perhaps principal value in this larger initiative. As just to try to give a couple examples in our own context, using the data that we've already seen. If you'd like to go to the next slide, Matt, thank you. So this slide was presented earlier by Nassim, and it represents various projections depending on the kinds of interventions that are used. And it's strikingly different, I think, from even Broome County's graph, which has its own unique elements to it. Couple of takeaways from this, which again, I think really do help us think about the way in which we intervene. One of them is that if you see the purple line, and that's in contrast at the moment to the sort of pinkish line. The purple line is naloxone distribution, essentially. And we will see a much more immediate decline in overdoses with that. But in time, it is going to be less effective, at least less effective than an emphasis on MOUD. This isn't, of course, to pit one against the other, but it does acknowledge that there is a kind of ceiling of effectiveness of Narcan distribution. We have data now in our own county, or at least in the city of Jamestown, our largest city, that in about a third of the instances in which EMTs respond to an opioid overdose, a bystander has already administered Narcan. Now, a third isn't 100%, but as a form of first aid, appropriate first aid applied to a medical emergency in the community, it strikes me as a fairly remarkable prevalence of the use of this life-saving medication. And that, of course, doesn't even account for the multiple instances where an overdose is not reported, and almost certainly also included the use of Narcan. By no means suggesting that our efforts to scale up Narcan aren't important and that we can't do better, and we will. But it does acknowledge that there is a ceiling to that effect, and it's probably largely the fact that, of course, Narcan is only going to be useful if somebody's with the person who overdoses. And so it's not going to do, it's going to have a ceiling in terms of its effects on ultimately decreasing overdoses and overdose fatalities. And that line, I think, kind of maybe does represent that fact. And so we don't want a narrative that puts, again, not pitting anything against each other, but we have to reckon with the fact that our long-term effectiveness is really got to be driven by the pinkish line, namely MOUD. And that is where we really want to put our emphasis. In fact, in our own county, it is very rare for us to find buprenorphine in the toxicologies of those who have died, which does seem yet more evidence on a sort of local level of the effectiveness of MOUD, namely that people on it, it's rare to find them having overdosed. Of course, the best model, and the one that we're employing, is the combination of both the naloxone distribution and MOUD initiation and retention. And that represents that, it represents the kind of yellow line, which is covering the brown line, which represents the awareness, seemingly to represent that our awareness levels are actually fairly high in the county. Perhaps already we've, in a sense, perhaps made almost as much hay out of that intervention as can be done, although for other reasons, there's always good cause to keep awareness levels high. Next slide, please. Third kind of insight that I think the system dynamics model has helped us with, next slide, are setting the expectations for the timeframes. And this is a kind of weighty and difficult projection, but again, perhaps challenging a narrative that's looking for an immediate change to this problem, which we all want an immediate turnaround for. But if you have a look, let's see the next slide, if we could. So again, same slide that we just saw, with the projected impact of those combined MOUD and OEND interventions will bring us back to a pre-spike level, which wasn't exactly a place of real satisfaction by any means, but by all projections here would not happen until, next slide, please, 2028. We hope, candidly, the model is wrong on this point, but regardless, I think it does highlight the fact that well-informed projections don't anticipate that this is going to be turned around to any kind of levels that we once saw, which again weren't exactly great, but it's not going to happen quickly. It's heavy news, but it's realistic, and it helps us in our long-term planning. It also helps us to acknowledge that while short-term impacts might be less than we wish they were, they are not cause for giving up, that we need a sustained ongoing approach. Next slide, please. And then finally, to wrap up my portion here, next slide. The system dynamics model, I think, helps us acknowledge that insofar as the complexities of addiction and overdoses have these multiple feedback loops and all kinds of interplaying dynamics that are very complex, that the reality that there can be unintended consequences has to be kept in mind. Of course, if I knew what those unintended consequences were, they wouldn't be unintended. But I think, for an example, an impulse to, and in many instances appropriately, see people get hospitalized for opioid use disorder when appropriate, of course. This isn't an either or, but it does recognize that that does pose, in some respects, a unique increased risk if those treatment episodes aren't followed by very rigorous follow-up, insofar as people are then at much higher risk, lower tolerance, et cetera, for overdoses. Admittedly, that's a kind of a foreseeable consequence, but the care with which we approach this and the acknowledgement that every intervention has its potentials, but should be carefully monitored for its unintended consequences, again, I think helps us think about how we approach this problem here in our county. Next slide. And just to wrap up, the same slide you saw earlier with McKenna, but I want to just give a special shout out to these, all of our partners, and the ones that don't have a logo as well, namely the many of our individual residents, some of whom have tragically lost family members, who have turned that pain into an investment into trying to help other families avoid that. And many others, people in recovery, et cetera. We just really want to give great thanks to. These are the folks who really make things happen. So with that, I'll turn that back over then to Matt.
Our first question focuses on integrating this modeling work into the HCS County Coalition work. So the question is, how do the counties use the projected results in coalition discussions?
I'll say in our case, it's useful, but for the reasons that I kind of just reviewed, it does need a certain amount of care, because it's candidly not always as happy and as sort of optimistic as we all want to see. So I will just say we definitely use it for the reasons that I've just said, but it really does require a kind of context and explanation. And I think, public health and day-to-day work, have a kind of tension between trying to shift a graph that represents aggregate data and the fact that many of our partners are working with individuals whose lives literally could be saved today if the time, the circumstances were such. So, yeah, I just want to say, and look, it's this heady kind of stuff. So some will grasp it, I think, better than others. I hope I didn't offend anyone. I don't grasp it maybe as well as I'm sure I don't as well as some, but it takes a little bit of care. I'll just say that.
I will say I've sat in many meetings with you, Steve, and you were being very humble, and you do grasp it. And Jillian, I see you've come off mute.
Yeah, I was just going to say that in Broome, similar to what I had talked about during the presentation, we've used the model more with our data subcommittee, as it gives us more time and a more one-on-one experience with the model, and then bringing some of that information back to our larger work group. Like Steve said, it can be a little overwhelming, but our data subcommittee is really excited about data, and I'm always really excited to bring this to them to get their feedback. I know that we were able to talk about how the model might have needed to change based on what was happening versus what some of the data sources were saying.
Great, thank you. Now, my next question that I'm seeing is for our modelers, and it's all about change. So how have you had to adjust the model's behavior significantly over the course of the study? For example, accounting for external factors such as COVID-19, changes in prescribing laws, etc.
Yeah, so I can maybe answer to that. So definitely the COVID impact we have incorporated. So the model, we calibrate towards data until 2019. And then for 2020 and 2021, with the start of COVID, we adjusted that by basically adjusting certain parameters regarding overdose risk and potency of the opioid supply. We understand that with the further spread of fentanyl and illicit supply, there's been a spike on the overdose risk, which has been incorporated. And also early in COVID, with all the crisis that happened, especially people vulnerable to using opioids had a increase in use, and the risk of overdose did have a jump in the early of COVID timing. But really after that, based on our estimations, what we understand, it's been primarily due to fentanyl and other illicit opioids that have had a sustaining effect of increasing risk of overdose across all counties, really. We also have incorporated some of the other effects of COVID, such as some drop in ED visit rates because of understanding that the pandemic was happening. But not much on really MOUD initiation or retention based on our evaluation, and also with other backup data and lit review that many reports are saying that. So there's been a lot of those. In terms of policies and regulations, there's been more recent changes. We understand with the MOUD waivers. We're still exploring that. There's going to be, of course, a shift in capacity potentially, but we also understand barriers to MOUD are not necessarily really capacity. I mean, there's a lot of barriers that prevent people from initiating.
Thank you so much, Dr. Simbachi. So we have time for one more question, and that question is, what are the key themes and takeaways you would like audience members to leave this webinar with?
Well, I'll be brief and just, in a sense, reiterate what I said. I find there are all kinds of oversimplistic narratives that attempt to capture the complexities of addiction. And not only do we acknowledge and need to that there are far more dynamics at work, but that there are tools that can really help us anticipate how those are going to interplay.
To jump off of what Steve had said, I think for us and what I'd like our audience to take away is that we can use this model to really highlight not only the things that we can do, the things that we have access to, the interventions that we can implement, but it shows what happens if we don't do these things too. And that was, I think, our group's biggest takeaway is if we don't do these things, we're not going to get the results that we want, even though the goal of the study is reducing overdose fatalities by 40%. Broome County's, Chautauqua's, probably all the counties involved and the counties outside of the study is a rate of 0. And we can utilize these models to help inform what we do and what we don't do.
And James, I might just add that as Jillian and Steve and the presentation overall, I think is already kind of highlighted, it really is a combination of these evidence-based strategies that makes the most impact. Even though we can build a model that actually works well, performs well across so many different communities, you can see that the dynamics of things like community awareness are important, more important in some settings than others, and really kind of like drilling down into like why that is, I think can really help facilitate a narrative with key stakeholders that builds these partnerships and helps people really anticipate like what the near future might be and keeps, you know, eyes on like the ultimate goal. I think also like with respect to the question about COVID and the impact of COVID and fentanyl, a lot of that was, of course, not seen when we started the Healing Community Study. And it just underscores how the evolving complex nature of the epidemic really shapes what we're doing now. The modeling can be, you know, used to really kind of try to factor in things as we kind of like see what is kind of like unfolding. And it helps us actually, as modelers, build more confidence in the structure of the model to be able to kind of like factor in new things that we might not be even talking about today, but the model could kind of like address later.
That's so wonderful. And it's so wonderful that the model can look to the future. But now let's look at the present. With 1 minute left to go, I just wanted to reiterate our gratitude and our thanks, especially to our panelists. The New York HCS webinar series was created to give an opportunity for the broader public to be able to see this amazing work that is happening within our study teams and in our counties. Our SDM team just provides such a wonderful representation of the innovation that is happening through the study. And McKenna, Steve, Jillian, working with you all each and every day in Broome and Chautauqua Counties is such a pleasure to see the impact that you are making in the counties that you work in. Again, this is part of the Healing Communities Study webinar series in New York. We hope that you will join us for future events, and we thank you for your time today. Have a great evening. Goodbye.